you through to some housekeeping matters. You can choose the language in which you'd like to listen to the press briefing by clicking on the interpretation globe below on the right side of your screen. Tout d'abord, bonjour les collègues journalistes. Pour les questions d'ordre pratique, la conférence de presse se déroulera en anglais, mais vous avez le choix de choisir la langue dans laquelle vous souhaitez bénéficier de la traduction en cliquant sur le globe en bas à droite de votre écran Zoom. Thank you and welcome everybody. On our panel today, for introduction, we have Dr. Patrick Otim, who is a program area manager, WHO Africa. We have Dr. Janet Diaz, who's joining us from the DRC, who is the head of Safe and Scalable Care Unit from our WHO headquarters. We also have Dr. Sheila Nasiriwe, who is the Health Emergency Officer in charge of immunization at WHO Regional Office for Africa. My name is Otto Bacano. I'll be moderating the press briefing today. A warm welcome to you all. So to kick us off, we'll go straight to Dr. Patrick Otim to give us a brief update on the situation since the declaration of the outbreak and the efforts being done to respond. Over to you, Patrick.
Thank you very much, Otto. Good afternoon, colleagues and members of the press. Thank you for joining us today. We are here to provide an update on the Ebola outbreak in Kasai province in the Democratic Republic of the Congo, the progress we have made together in protecting lives. It has been exactly 2 weeks since the outbreak was declared. The government of the Democratic Republic of Congo acted swiftly in declaring the outbreak within 24 hours of confirmation, as is required under the international health regulations. This action made it possible for WHO and partners to quickly mobilize expertise and resources needed to respond to this Ebola outbreak. Special thanks to the World Food Programme and the UN Peacekeeping Mission in the Democratic Republic of Congo, MONUSCO, whose support in providing aircraft has been very crucial in getting teams and essential supplies in and out of Bolape quickly. We are equally grateful to the dedicated partner organizations standing shoulder to shoulder with the Ministry of Health and us on the ground. Above all, we salute the extraordinary bravery of the healthcare workers and communities that are impacted by this outbreak. Your courage and determination is the backbone of our collective fight against this outbreak, and together we can stop it. So far, there have been 48 cases, of which 38 are confirmed and 10 are probable. Sadly, there have also been 31 deaths as of today, 17th of September. However, it's important to note that these figures continue to be updated based on the field epidemiological investigations. In this outbreak, we have seen that women are more affected, accounting for around 55% of cases. This can largely be attributed to the caregiving roles that women play in the community. Progress has been made in disease surveillance. More than 900 contacts have been identified so far, with daily follow-up rate of 97% in the last 24 hours. This means that individuals who may have been exposed are being monitored daily, therefore reducing the chance of undetected chains of transmission. 15 patients are currently admitted and are receiving care at the Bolape Ebola Treatment Center. And thanks to early detection and improved care, 2 patients recovered and were discharged. In support of the government, WHO has delivered 14 tons of essential supplies, including PPEs, laboratory materials, therapeutics, and tools. These are already in hands of healthcare workers on the ground, enabling them to protect themselves while saving others. More shipments are on their way. Vaccination remains a vital pillar of our defense against Ebola Zaire species. We currently have 3,500 doses available in the country, with 760 already delivered to Bulape. More than 500 healthcare workers and contacts have received their vaccination, offering them crucial protection. Additionally, a further 45,000 doses are expected to arrive in Kinshasa soon. Prioritizing vaccination of healthcare workers and high-risk individuals protects them and reassures the community of effective action. Community engagement is a critical component of the response. With our support and working with partners, communities and religious leaders, healthcare workers are working tirelessly to share accurate information, calm fears, and encourage people to report symptoms early. As a result, families are seeking help more quickly, and there is growing trust playing a crucial role in saving lives. There are still challenges. Poor infrastructure makes access to some of the affected communities difficult, and also with Kasai's proximity to Angola, there is a risk of cross-border spread. This is why preparedness efforts are being extended to the surrounding provinces as well as the neighboring countries. In the coming days, our priorities are to maintain and strengthen surveillance, expand treatment and protection of healthcare workers, reinforce the infection prevention and control in health facilities and in the communities, and keep building trust with the communities so that no one is left behind. Our response will go hand in hand with a long-term investment in the resilience of the health system, strengthening core services, infrastructure, and training to ensure that communities are better protected, not only against this outbreak, but also future health threats. We thank you all for the continued support and will continue to keep you updated as the situation evolves. Over to you, Otto.
Thank you very much, Dr. Otem, for those updates. Now we cross over to Dr. Diaz, who's joining us from the field. I hope your connection is on. Just confirming that we have you online. We do apologize that connecting from Bulape is a bit challenging. We'll keep checking. If she's back online, she will give us an update on clinical care and case management. We move over to Dr. Nasiriwe to give us an update on the vaccination efforts ongoing, where we are, and what the next steps in terms of our priorities in vaccination are. So over to you, Dr. Nasiriwe, for your update.
Thank you very much, Otto, and welcome members of the press. So regarding the Ebola vaccination, DRC had about 2,000 doses of the Ebola vaccine available that were pre-positioned in the country before the outbreak was declared. And they also received an additional 2,000 doses from the International Coordinating Group on Vaccines. And this was critical in ensuring that vaccination of the population groups at high risk were vaccinated quickly to prevent further spread. Vaccination started on the 13th of September in Bulape, where most of the cases have been reported. A ring vaccination approach is being used, and this is targeting contacts of the cases, probable contacts of the cases, or people who are likely to come into contact with the cases, and then also importantly, the healthcare workers and frontline workers. As of yesterday, about 284 healthcare and frontline workers had been vaccinated in Bulape at Mweka, and also 307 contacts and probable contacts in Bulambai and Bulape had been vaccinated. So in total, about 491 people had been vaccinated. The ICG, as Dr. Patrick has just mentioned, has also approved an additional 45,000 additional doses, and these are expected to arrive in the next 2 to 3 days. Once we have these vaccines in country, we expect to also expand the target groups. And in addition to the ring vaccination, where we are targeting mostly contacts, we expand and cover all the populations at risk of getting infection. That is covering all the areas where cases have been reported. And the vaccination has not been implemented as fast as would have desired it to, because of accessibility challenges, which have really caused delays in transportation of vaccines. But these haven't been insurmountable, and they have been addressed. So in the coming days, as soon as we receive the additional doses, we'll be scaling up vaccination. Over to you, Otto.
Thank you very much, Dr. Ntasire. Apologies for misspelling your name at the start. Thank you. I do not believe that we have Dr. Diaz online, or we're still having challenges reaching her. Oh, we are here always. Thanks. So we'll cross over to you to give us an update on the clinical care aspect and case management. She's joining us from Bulape. So over to you, Dr. Diaz, for your update. Can you hear as well?
Thanks so much. Can you hear me? Can you hear me?
Yes, please
Hello,
carry
can
on.
you hear me, Otto?
Yes.
Okay. So thanks for bringing me on. Just to discuss here, scaling quality clinical care during an Ebola outbreak is always a challenge. And here so as well because of its remote nature and the in the limited health services within the region prior to. But the team here under the leadership of the national under the local leadership of the medical director of the General Hospital of Bulape we're able with the rapid response teams to set up and establish a dedicated place to care for patients. So that's what we call a treatment center. Since then, the national team and working alongside the national incident management team, as well as partners such as Alima and MSF and WHO as one of the partners, we've helped to establish a dedicated treatment center that is caring for the patients with suspected disease and also with confirmed disease. And I wanted to highlight a few things that are important around the treatment center. One is the establishment of a safe structure where to care for these patients. And that includes that there's good circuits, that there's good safe patient flow, as well as flow for the staff, and that the donning and the doffing. So all those things are in place. And it's good to see that. As well, that all the supplies are there, the medicines, the equipment, and the important infection prevention and cleaning materials, and all that's in place. All teams to increase building capacity with the local staff, so everyone is familiar on the best practices for the care, and then of course the systems are.
We lost you there, understandably, given the connection problems. We'll try to reestablish connection as soon as possible, and we'll have her on standby for questions. So as when we establish reconnection, we'll have Dr. Diaz back online. So thank you, Dr. Tim, Dr. Ntasire, for the updates. Do we still have you?
Oh, I came back. But just to say that there's also access here to the monoclonal antibody Mbanga, which is the MAB114 that was actually discovered here in this country. And that has been made available to 16 of the confirmed patients. So that is a great intervention. So in addition to that, the patients are getting fluid resuscitation, treatment for co-infections, and monitoring. And we are now working with with all the partners to support the ministry and the setup and establishment of another treatment center that has all the innovative techniques that we've been developing over the years to best care for these patients.
Thank you, Dr. Diaz. I think we sort of got the summary of it. If you can be able to stay online and pick questions as we open it up now to our journalists. Thank you to our panelists for all the updates that we've received. So just to remind you that this is a media briefing. We'll be taking questions from reporters who are attending, and by raising your hand and also letting us know about the media organization that you're representing. You will be unmuted once your turn comes to ask your question. So do also know that you can put your questions in the Q&A function in the Zoom function below. We can take those questions as well if you prefer to write them in. So we have some hands up. Could we go to Paul, and could you be colleagues and meet Paul so you can have your question to the floor? So specify who you want you're directing your question to and your media organization. Over to you.
Thank you very much. It's Paul Adepoju from The Lancet. So I want to know, you mentioned the use of monoclonal antibodies. So I'd like to know the settings around its deployment and what decides who gets the monoclonal antibodies. Then,
sorry, Paul, your line is a bit faint. Do you mind either moving closer to the mic or raising your voice a bit? We are struggling to get your question.
can you hear me now?
It's much better. Carry on.
Okay, okay. My question has to do with the use of monoclonal antibodies. So I'd like to know whether this is in a clinical trial setting or a rollout setting, and what decides who gets the monoclonal antibodies. I also want to know the circumstances around improving the outcomes. What is in place to ensure that patients that are individuals that are able to be detected early so that the outcome can be much better than we've seen in the past. Thank you.
Thank you. Dr. Diaz, do you still have you online?
Yeah,
Did you get the question? Whether the use of MAB 104
I'll try here. Thanks for the question. Is a recommended drug to give to patients by the WHO with Ebola virus disease Zaire. So that's one of our clinical recommendations. So that's the standard of care, as well as an alternative is the Inmazeb, which is the Regeneron product. These two were tested in the clinical trial done in DRC in North Kivu back in 2019, which showed a reduction in mortality, so increased lives saved. Here, the INRB, the National Institute Biomedical Research, has had a stockpile of these patients, and it's being used under those conditions. They are being delivered as the standard of care with good fluid therapy, resuscitation, and a dedicated therapeutic team, local, national team that is responsible. And then afterwards, over.
Thank you for that response. You are in and out. Maybe Dr. Tim, if you have any further clarifications, just to ensure that if there are any gaps that were missed because of not very good connection, can complement. Thanks.
Yes, thanks to Paul. I think as Janet was saying, so the monoclonal antibodies now, particularly when we're speaking of the Ebola Zaire species, that they are part of the standard of care. So they are offered systematically to all the confirmed cases that have been admitted at the treatment center. But he also did raise an important question: is what are we doing to improve the outcomes? And this is a very critical aspect. Now, I just want to break it down. So first of all, we know that for Ebola, the chances of survival or improved outcome is directly linked to how early the treatment is initiated. So identifying the reason why we are trying to scale up the surveillance and the contact tracing so that suspected cases are identified early and they are isolated, and the optimized supportive care is provided to them early. So that is the first aspect. And then at the treatment center, as Janet was mentioning, then we have the standard of care, which involves resuscitation, management of the co-infections, symptomatic management, and ensuring that the patient receives an optimized supportive care round the clock, which is critical then to improve the chances of survival. So that early detection combined with the optimized supportive care, which is really comprehensive, including nutritional support, by the way, which is a very critical component of this, are factors really that are very, very important in improving the health outcomes, and that is what is being done on ground. Now, one of the issues is also that because we have patients hospitalized in isolation, you need to have healthcare workers moving in throughout and monitoring them and ensuring that the vitals are checked and any other change that is there is detected and managed quickly. And because for you to do that, you have to have an appropriate treatment facility that is safe and that healthcare workers can transit in and out without the risk of them being exposed. And that is what the teams have done to adapt the facility that was there to make sure that the patient flow is efficient, the flow of patients and healthcare workers is efficient. And then now they are expanding and establishing a new standard place so that the environment is conducive for the healthcare workers to stay inside there longer and ensure that they provide round-the-clock care for the patients.
Thank you, Patrick. We have Ope Adetayo. If you can be unmuted, please let us know what your organization is, and you have the floor.
Hi, thank you, Otto. My name is Apaletayo. I am a West and Central Africa correspondent for the AP Associated Press. I just wanted to ask my question towards Shirley and Dr. Patrick on the challenges they mentioned towards getting vaccine. Can they expand more on it? The conflict affecting the vaccine access. What are the specific challenges they are facing? Can they talk a bit more on that, please? Thank you.
Thank you, Ope. You can lower your hand now. Over to you, Patrick, about the challenges, if you can expound a bit on that.
Okay, thank you very much, Ope, for the question. So we had prepared and prepositioned 2,000 doses of vaccines in country before the outbreak was confirmed. Now, the first challenge was the logistical challenge in two components. One is it was taking 4 days to move by car from Kinshasa to Bulape. And so moving the vaccines by road was very challenging. The second one is the nature of the vaccine we are dealing with. It requires ultra cold chain, so you need to keep it at minus 80 degrees Celsius. So if you move it out and you put it in some of these cool boxes and you drive it for 4 days, you are likely to lose the potency of the vaccine. So we had to work around this to ensure that we can be able to move the vaccines quickly and safely and get them to the field. So there have been two solutions that were put in place. One was when we had the air bridge established, we were able to fly the vaccines in over a short period of time. And then two, we are then moving the vaccines in small bits from Kinshasa to Bulape because we have some storage facilities that can keep the vaccine at optimum temperature for at least 8 days when you are doing the vaccination. So we now have to have a relay system that we move quantities that can be administered within short periods from Kinshasa to Bulape and then administered. And then, as Sheila had mentioned, we have already requested from ICG and approved additional 45,000 doses. So in terms of now the availability of the vaccines, it is not a problem. It's now the issue of the logistics of moving it. And finally, we are also now working to ensure that an ultra cold chain facility is established in Bulape so that then we can move these large quantities of vaccines that will be in Kinshasa to be very close to the hotspot, and then we can be able to administer them quickly to the targeted population.
Thank you, Patrick. In terms of vaccines, do you know whether, Sheila, you have additional comment on that?
No, I think Patrick has really said it all. Yeah, thank you.
Thank you very much. We got the next hand up from Emery Makumeno. Please introduce yourself and your media house and the person to whom you're directing the question. Carry on.
Hello, can you hear me?
Yes, we can hear you, but if you could speak a little louder, that would be better.
Oh, thank you. My name is Emery Makumeno. I'm joining you from Kinshasa, and I am with the BBC News here. My question is also going back to the vaccine. I know new batches have been ordered. When are these vaccines expected to reach Kinshasa? That's my first question. And the second question is concerning the treatment. How many are there available in Bulape? And I just wanted to know if there will be also other orders for additional treatments for the country when it comes to this outbreak? Thank you.
Thank you, Emery. Sheila, to you about the dates of arrival of vaccine doses, and then Patrick, you can take it over in terms of the treatment. Over to you, Sheila.
Okay, thank you. So for the 45,000 doses, they are expected to start arriving on 19th. They are going to be shipped, brought in 3 batches of about 18,000 doses. So the first batch will arrive on the 19th, the next will arrive on the 20th, and the next will arrive on the 21st. So in the next 2 days, we should be having the vaccines in country.
Thank you. Patrick, on the treatment question about the doses.
Thank you. So, concerning the MAB 114, which is the one that monoclonal antibody that we're using currently, we initially had 100 doses or treatment courses that were available in Kinshasa. Of these, I think 70 doses were moved down to Bulape. And as Janet had mentioned, so far I think they have used 16 of those, so there is still some doses available that will be used over the next coming days. Then we are engaging with the manufacturers of this particular monoclonal antibody to see that we can be able to get doses made available. There are also engagements at the HQ level with the manufacturers of the second monoclonal antibody, Regeneron, so that we can get an additional stock which can back up the one that is being used on ground now. So yes, some doses available. They are not many, but we are actively engaging, and maybe in the subsequent briefing, once we have gotten concrete commitments, we'll be able to update on that.
Thank you, Patrick. Another question from the to take the floor from Stanislas Diomi. You have the floor, your media organization, and your question. Stanislas, can you unmute? Please go ahead, Stanislas. Okay, maybe you have issues unmuting. You are muted from our side. Okay, then we'll move.
Allô?
Sorry, are you there?
Vous m'écoutez?
Stanislas?
Vous m'écoutez?
Oui, on vous entend.
Oh, voilà. Je disais, je suis Stanislas Dioumi de Radio Okapi. Alors, ma première question, c'est en rapport avec cette flambée d'Ebola, qui est la 16e qui touche la RDC. Mais lors de précédentes épidémies, notamment à Beni Butembo, on a pu constater la méfiance, voire l'hostilité d'une grande partie de la population sur fond de fausses informations en lien avec cette maladie. Est-ce le cas également à Boulapé? Et la deuxième question, c'est me rassurer par rapport au système de stockage de vaccins. Comment ça se passe sur place? Merci.
Thank you, Stanislas. If I can summarize, this could go to you, Patrick, about the issue that was faced in previous outbreaks about hostility from the community, whether this is something we're experiencing currently in Bulape, and then about the vaccine storage and transportation, which I think you've also touched on a bit, Patrick. But maybe Sheila, you can also expound on that. These are the questions from Stanislas, who is with Radio Okapi. So over to you, Patrick.
Thank you very much, Stanislas, for the question. We always say that communities are at the center of any outbreak control, and getting their support and collaboration with all the response interventions is critical. I would like to state that in this particular response, we have not recorded what we'll call acts of hostility from the community. Understandably, there have been some few incidences of hesitance, for instance, to be admitted to the treatment center, but these have been resolved by the community engagement teams. There have been 3 of these instances. These have been quickly resolved once the community engagement teams and the experts have gone and explained to the family why it is important for this person to be taken to the isolation center and what is going to happen there in terms of the care that is going to be provided. They have responded positively. But I would like to state that also this outbreak is happening after almost 2 decades of a similar outbreak happening in Kasai. So a lot of the people do not have very good memory of this particular disease. So that's why we are not taking the issue of community engagement and risk communication lightly, that there has been massive effort to try to map out the community leaders, the religious leaders, to engage, to pass messages, to address their concerns, and ensure that we are responding in a way that is sensitive to the culture of the population, but also that mitigates the risk of transmission. So far, we are very grateful for the community leaders for their role in ensuring that there is maximum cooperation and there is no acts of hostility that has been registered.
Thank you, Patrick. Sheila, over to you on the question about vaccine storage and transportation.
Thank you, Otto, and thank you to the reporter. So the vaccines need to be stored at ultra cold chain temperatures, so about negative 80 degrees Celsius. And as Dr. Patrick has highlighted, there was no ultra cold chain facility in Bulape. However, this is currently being put in place. But in the interim, we are having small batches of vaccine doses being thawed in Kinshasa and airlifted to Bulape, and to be used within 14 days, because once they are thawed or taken out of the ultra cold chain, they need to be kept at 2 to 8 degrees Celsius for up to 14 days. So they must be used within 14 days. And we've also realized that they are able to use the small batches that are being delivered within the 14 days. So the plan for the next batch that we are expecting from the ICG, as we also plan to scale up vaccination, is to have more quantities of vaccine being thawed from Kinshasa, being transported in coolers by air. And we plan to increase the number of vaccination teams to ensure that we have more teams to be able to utilize the doses that are going to be delivered in the coming days within the stipulated 14 days.
Thank you, Sheila. We got questions in the Q&A function, and 2 from Janet Beatrice Kazi from SciDev. And the 2 questions are as follows in French. I'll try to summarize and direct to this might come to you, Patrick, about so she's mentioning that there have been from their sources a climate of panic from the affected zones, localities, about populations denouncing others as people of contact, in the sense that if you are identified as a contact, then you're denounced. And then it causes hesitancy from the community. Is this something that WHO experts on the ground have encountered? The second question is about preparedness in the neighboring countries. And could you elaborate on what exactly is being done? I think we had mentioned previously about the 10 priority countries where we're focusing on. So what are these actions that we are undertaking? So over to you, Patrick.
Thank you very much. I will answer the question about the community reaction, and then my colleague, Dr. Charles Njuguna, is online. He's responsible for the readiness, so I will give him to talk briefly about the preparedness and readiness in the neighboring countries. Now, the issue of population movement or panic, there were initial reports at the early phase. When there's a rumor that people are dying and people do not know what the cause of the death is, the normal human reaction will be people want to move away from there. So initially at the early phases when this was still being investigated, this was reported, but then after we have had the confirmation and then the response has been initiated and there's ongoing engagement with the population, we have not recorded new incidents of people panicking and moving, because the initial fear was it is an unknown disease and people do not know what's happening, what is killing people. So that is what is being addressed progressively during the sessions, the outreach sessions that are being held with the different communities. And it's really, really important. I have to emphasize that the media houses and all of us who are stakeholders are able to communicate that this is a disease that we know how to deal with, and there's no need to fear, there's no need to panic, and the measures that are being recommended on ground, that if the community collaborate and follow in terms of those contacts who need to be observed for 21 days, those who need to get the vaccine, they accept and they get the vaccine. The sick people are reported early and taken to the health facility so that they don't expose people in the house, and they are cared for, and any death that happens should be reported and people should not participate in unsafe burial. With all these measures, we can stop the outbreak quite quickly. It has been done in DRC, like Stanislaus mentioned. This is the 16th outbreak, and the last outbreak in Beni was stopped in record time, and there was only one case because we're able to implement these measures quite quickly. So it's something that we can do, and we continue to encourage that we pass this message along.
Thank you, Patrick. Yes, we also have Dr. Njuguna with us from WHO Africa. Over to you about the question on preparedness, on what exactly we're doing in the priority countries that have been identified for support.
Yeah, thank you. Thank you very much, Otto. As Dr. Patrick has mentioned, that we have about 9-10 neighboring countries that we are focusing in terms of preparedness. We have already done the risk categorization, and Angola falls under priority 1, while the other countries fall under category 2. We have been able to do risk assessment in all these countries. We have provided the necessary tools to the countries' ministries of health, and they are being supported by WHO. About 7 of them have already finished the whole process. We are following up with the remaining countries. On average, when you look at the whole picture, the readiness in those countries around moderate, what you call moderate level, in terms of capacities in 11 important pillars. It's currently about 57%. There are some pillars, they are very strong. Some pillars, they are not that much strong. But those readiness assessments help the countries now to be able to develop their contingency plans and be able to see what are the key priorities. And we are supporting these countries in terms of the contingency plans. The other areas of focus is the issues of points of entry, and especially for the Angola DRC border. We all know that diseases don't need permission to cross borders. They don't need visas. So we are working with Angola, ensuring that the points of entry, they are strengthened in terms of capabilities. And also we are working with our sister agency, IOM, who are already on the ground in Angola. They are doing population mobility mapping so that they can be able to advise us in terms of how populations are moving in those regions that are affected. We have already conducted a webinar for all these countries and partners in the region so that we can all work together to support the preparedness and readiness in these neighboring countries. And some of the countries have already started testing their contingency plans in terms of simulation exercises to be able to see how good are they in terms of readiness to deal with any imported case of EVD. Thank you, and over.
Thank you very much, Dr. Njuguna. We have 2 questions from Regine Matata, who is from actu10.com in the DRC. And I'll combine these questions and coming over to you, Sheila. One is about generally in Africa, these people are aware about vaccines, that they may be dangerous and could be deadly. What are some of the things that WHO is doing to sensitize communities before the start of vaccinations? And secondly, what are the specific qualities of the available Ebola vaccine that sets it apart from other vaccines administered in previous outbreaks?
Thank you for that question. So as with most vaccines, the communities need assurance that the Ebola vaccine is safe and it is effective. And we also need to reassure them on the benefit of getting vaccinated. So the vaccination team on ground is working very closely with the surveillance and the risk communication and community engagement teams in the field, where cases have been identified, especially the contacts and close people around the cases, to sensitize them on the benefits of the vaccine, answer any questions that the community has, address any fears, and make sure that we get trust from the communities. And I can say that so far, there hasn't been hesitancy from the target groups that are being vaccinated right now. And just to also reassure that the vaccines are safe and effective. The Everbo specifically has been pre-qualified by WHO. We have 2 vaccines that have been pre-qualified by WHO, the Everbo and also the Zabdeno-Vebia vaccines. However, only the Everbo is currently recommended for use during outbreaks because it's 1 dose, and we are able to quickly raise immunity after the 1 dose, about 10 days after vaccination. Whereas the Zabdeno-Vebia vaccine is a 2-dose vaccine, and the second dose has to be received 8 weeks after the first dose. So it is not a vaccine that is recommended for use during outbreaks. That is why the Everbo is currently the one recommended for use during outbreaks. There are a number of other vaccine candidates that are currently still undergoing studies, but so far we have these 2 which are recommended for use against the Ebola virus disease. Over to you, Otis.
Thank you very much. We have the next question in the chat coming from Lucia Blanco, who is the Spanish International News Agency, EFE. And she would like to know exactly how many people, just need clarification from what you had mentioned previously, on how many people exactly have been vaccinated so far, how many vaccines are available at the moment on the ground, and secondly, who is financing the 45,000 vaccine doses that are being procured and to be delivered to the DRC?
Yes, so as of last evening, that is as of the evening of 17th September, a total of 591 individuals had been vaccinated. That is 284 healthcare and frontline workers, and then 307 contacts and probable contacts have been vaccinated. And then for the vaccines available on ground, out of the 4,000 doses so far received in Kinshasa, 1,760 have already been transported to Bulape as of this morning. So in addition to the 760 that was transported and has been used, an additional 1,000 doses were also transported to Bulape last evening. And then we are expecting an additional 45,000 doses from the ICG. And this comes with funding, vaccines and funding, both from the ICG.
Thank you, Sheila, for that. Dr. Njuguna, any additions on that?
I think Sheila has answered it comprehensively. Yeah.
All right. We go to the next question. One more from Emery Macumeno, who had asked on the floor previously. And this comes to you, Patrick. It's about contact tracing. And so the question is, how are the contact cases being monitored? Specifically, he wants to know whether they are locked down at home or whether they're restricted from moving, or if they're restricted, are they provided with food? So basically the mechanisms which we're using to do contact tracing.
Okay, thank you, Emery, for the question. Yes, contact tracing is a critical component of control. Currently, the contacts that have been identified and listed are advised against moving, because moving out of the houses or the community increases the risk of further transmission. So it's not a strict quarantine per se that you want to, but they are advised to stay at home, and they are obliging with that. And they are then monitored by contact tracing teams. So contact tracing teams assigned a group of contacts, so they check on them in the morning and in the evening to ensure that there has not been any change in their health status in the period that they have not been seen. Now, we have been having discussions with the WFP, the World Food Program, in terms of, as we implement these measures, we know that a number of our communities, for instance, is daily subsistence, so they get their food livelihood on daily basis. So there's already a plan in motion by the World Food Program to be able to do general food distribution in particularly Bulape, in the areas that are affected, so that these people, that their movements are being restricted. If the food items they had in their houses are now getting finished, and then they will not be facing, food shortage at this time. So it's already in motion, and I believe in the next few days we'll be able to do general food distribution. The WFP is also then supporting with the provision of food for the patients that are at the treatment center. So those are the two nutritional aspects that have been added to the response, to ensure that we do not only focus on the clinical and epidemiological side, but the nutritional and social well-being of the contacts and the families, because a number of them may be the breadwinners for the family as well, is taken care of. Yeah.
Thank you, Patrick. We're almost exhausting the questions in the chat. We'll just take one more from Alexandra from RFE. And Sheila, this would come to you about expounding a little bit on the challenges of vaccination. Is it remoteness? Is it accessing the people who are contacts? If you can expound on that, then with that, we can start rounding up the briefing for today.
Yes, so as Patrick had already highlighted, the challenge really was the remoteness of the place and getting vaccines from Kinshasa to Bulape at the start. But this has been addressed, and at the moment, transporting the vaccines is no longer a challenge. But also, as we know, with getting the people to be vaccinated, that is through the surveillance teams, is always challenging in those kinds of contexts. So that's why, in addition to the ring vaccination, where we have challenges with locating all the contacts, we are going to also add the geographical targeted vaccination, where we'll expand the groups of people to be vaccinated, and we'll be vaccinating all the people in the areas where the cases have been reported, and not necessarily just the contacts of the cases.
Thank you. We'll start rounding it over here, and coming to you, Patrick, as we wind up. There are questions regarding from Paul, a follow-up question, and also from Ope Adetayo, who also asked question on the floor. And what is a projection? This is from Paul Adepoju. What is a projection regarding the number of people and regions at risk, and how the response is overlapping with the response to Mpox and other public health events in the DRC? If you could take that together with Ope, who is asking how many districts have the disease spread to now? So I think here we're talking about health zones in Kasai province. Over to you, Patrick.
Okay, thanks to Paul and Ope for the questions. For at this point, in terms of projection, it's I would like to delay that because we are trying to improve on the investigation, listing of the contacts, and getting all the chains of transmission identified. So any projection now, one can give, but it will not be very accurate. And my priority and priority of the team is really to try and ensure that my target is for the next 1 week, that all new cases that we get will be coming off a contact list. That means that we would have identified them as a contact, we listed them, we are following them. That would mean that we have identified all the chains of transmission and there is no missed chain of transmission. So that is the target that we want to focus on within the next the next 7 days. Now, in terms of the integration with Mpox, yes, DRC is facing multiple emergencies. It's not Mpox only, but there's also a cholera outbreak, but they're in different zones. For instance, in Bulape, where we are responding currently, we do not have Mpox transmission, but what we have been discussing and working on with the National Institute of Public Health as well as the EOC is that integration at the national level, because there are capacities that can be leveraged both at national provincial level, so that we do not have multiple incident management systems and different teams responding, that we're able to have some synergy in terms of, and also efficiency in terms of the resources that are being deployed. So in areas where we have a joint or concurrent outbreaks happening for Mpox and cholera, or Mpox and measles, that integration is being done so that we can be able to leverage the resources and use it to respond effectively. Now, in terms of the districts that are affected, so when we talk about health zones, we know that Kasai has 18 health zones, and so far the outbreak has been limited within the Bulape health zone. And within Bulape Health Zone, if you go down to the level of the communities, we have 14 communities or localities from where the cases have been reported. So it's fairly, for now, a little bit geographically limited, and that's why we are really rushing to ensure that we keep it confined within those localities within Bulape Health Zone, so that we can be able to contain it there quickly. There were suspected cases as part of enhanced surveillance that were reported from Mweka, from Mushenge, from Kakenge, the neighboring health zones of Bulape, but all of them came out negative, so which is reassuring. And we want to continue with enhanced surveillance and IPC measures in those neighboring health zones, as well as in the neighboring provinces of Kasai.
Thank you, Patrick. We have exhausted the questions, and the questions that we had live from the floor. We're now coming to an end of this briefing. Maybe just a quick word of conclusion. Start with you, Sheila, and then to you, Patrick. Just final words before we end. Over to you, Sheila.
Thank you, Otto. I just wanted to say that we've been grateful to have a pre-qualified vaccine at the start of this outbreak, because previously would use vaccines that are still undergoing studies. But now we have pre-qualified vaccines, and this has been important in ensuring that we have the vaccines timely to be able to contribute to controlling the transmission of the outbreak and controlling the outbreak. Over to you, Chair.
Thank you, Sheila. We have one reporter, Ronald, who would like to go live. We hadn't come to you, so if you could put your question to the panelist and identify your news organization and the person to whom you're directing the question as we finalize. Over to you.
Okay. Thank you so much, Otto. A quick one, maybe okay, my name is Ronald Dimsoke. I'm a reporter based in Kampala. I report for the Independent magazine. It's a quick one for Dr. Patrick, just to help me double check the numbers or the figures. He mentioned at the beginning of the briefing. I think he talked about 48 cases so far confirmed. Okay, 48 cases, but 48 confirmed and 10 probable. And then he mentioned 31 deaths. You could correct me on the figure. And then 15 patients so far receiving care. Are those the correct figures? And then finally, how do you generally describe the situation as you see it right now? Would you say it's something under control, in your opinion? Thank you so much.
Thank you. Over to you, Patrick.
8 confirmed cases. And then we have, that is laboratory confirmed, and we have 10 probable, which were
Sorry, Patrick, we missed the first part of your answer on the figures. I think it's important to take that again. Sorry.
Okay, thank you. So I was agreeing that with the Musoke, yes, that we have 38 laboratory confirmed cases. And in the last 24 hours, the epidemiological team did investigate and validate 10 probable deaths. And when we talk about probable, these are people who died with symptoms similar to the disease. Samples were not collected, but laboratory confirmed cases have been linked to them who are contacts. So that has been added to that list. So that brings it to 48 confirmed. So 48 cases, that is 38 confirmed and then 10 probable. Yeah.
And then there was the second bit of the question is your assessment about the outbreak.
Yes, the assessment of the outbreak. So we are 2 weeks into the outbreak. One assessment, one factor I would see, is there an expanding geographical spread? I would say, knowing Ebola, the way it spreads rapidly, I think if the situation was not under control, it would have expanded already beyond the Ebola health zone, but it has been limited geographically. We've just had, in the last 5 days, we only had one community that was affected, so moving from 13 to 14. So what I would say is that the rapid scale up of interventions has managed to slow down the transmission. So we were playing catch up in the first 2 weeks. Now we are almost at par with the virus. Now in the next 7 days to 2 weeks is what we really need to get ahead of the virus. We have the vaccine that is being deployed. We have the contact tracing teams out. We have over 900 contacts that have been listed and being followed up. So all the ingredients and necessary mechanisms are in place for us to be able to control the outbreak quite quickly. Of course, I always put a caveat that we are dealing with Ebola, and you can never have any complacence, because it is just one small incident. You can have a burial that has not been detected, and then people attend and you have an explosion. So we are always very, very cautious. So we are seeing that there's a slowing down of the transmission, because like in the last 24 hours, we didn't have a confirmed case. It is too early. But we have seen significant progress in terms of the improvement in contact tracing, that we are seeing 94% of the contacts that we have being followed up. We have seen an improvement in terms of the testing turnaround time, and the fact that we are not getting many confirmed cases than it was at the beginning. So it's a very good progress that we want to build upon. And we are quite certain that if we continue in this trajectory, along with the rollout of the vaccination, then we should be able to control this outbreak as soon as possible. But the factors have to be all put into consideration.
Thank you very much, Patrick. And with that, we come to the end of this today's briefing. Thank you very much for your attendance, for the questions, and thank you to our panelists for taking the time to fill the questions. We wish you a very good rest of the day, and I'll see you